Did you plug
Okay,
it in?
Bev, what is your show and tell?
The charger.
Have you heard of this book?
The book
It is
after.
Oh,
Bruce Grayson. A doctor explores what near-death experiences reveal about life and beyond. And it is experiences with his patients. I think he's a scientist of some sort as well, but I'm only on first chapter in like page 8. So my understanding is that there were a lot of people who were talking about, I think it was John who was asking last week about people who live through a death experience. I mean, they come back. And this gentleman it's my impression that he explained that he was thinking, oh, that you know what, it's just as the body goes, they're all kind of coming up with different stuff and whatever, or the same thing. Like, oh yeah, I saw a light and then I was fading back and blah, blah, blah. So I'm anxious to read it, but it is about death and dying and experiences. And it was on someone's book list. So we saw it at Costco. It's quite a bit less expensive than Amazon. And so I said,
But you have to buy them by the dozen.
Yeah.
yeah.
What?
no, we get just this
What
one.
was his
for
name again?
$17.
Bruce Grayson?
Bruce
Give us a
Grayson.
book report.
Bruce Grayson, okay.
Can we get
No,
a book
it's
report
just
then?
a reference, Bob. Yeah,
Yeah.
I have it. I'm only on page 8, buddy. I'll let you know next week. If providing it wasn't like a week like this one, I'll be able to report back. But that's always fascinated me. And I think, Becky, I'm really anxious to hear what you have to say.
Yeah, so this is great because our topic for the whole of Lent is death and dying, but you have found, Bev, death without dying, which is very exciting.
Well, it's near death.
That's right.
Here
Yeah.
And Dr. Lachenmaier's job is to get people all the way through death. So if her patients survive, she has not done her job correctly. So,
Wow.
so I will introduce Dr. Lachenmaier, who will be talking to us about kind of what happens as we die, kind of what should we know about and plan for in the not just sort of moments, but days, weeks, and months prior to our death. So Becky grew up in Montana, she tells me, and that was not west enough for her. So she went farther west to get her education at Pacific Lutheran University and then med school at the University of Washington, did her residency in Spokane, and then she and her husband, Chris, followed their families back to the Midwest, and they've been here since 2003. And we have pried her away from her two sons' activities so that she can be with us this evening. Becky's also a member at Faith Lutheran Church in Clive. So the ecumenical breadth of this group just
That's
got
right.
a third bigger. So Becky practiced internal medicine for 12 and a half years and then had the opportunity to pursue board certification in hospice and palliative medicine. And she has been the medical director for UnityPoint Hospice and UnityPoint at Home home care for almost 6 years. So we welcome Becky to tell us what we should know on the medical side. We had Ruby last week to talk to us on the spiritual side, but we also understand there is some sort of biological process that goes on as we prepare for death.
Well, thank you so much. Can everybody hear me okay? Good. I really appreciate your invitation to come and speak with you. And I think this is such a great idea to think about the topic of death and dying, particularly at this time in the church year, of course, but I think it's a topic that scares a lot of people and that people are intimidated by, but it's really a good thing to think about and talk about because, as I'm sure Ruby probably told you, the more people prepare for the end of life, both physically and spiritually and emotionally, the better things go. And I think that's an overwhelming theme that we see throughout hospice. So that's part of our job in hospice, is to help prepare people a little bit better for what happens at the end of life. And so I really think this is a great thing. Laura said you all had some questions specifically a little bit about what happens physically to our bodies. And so I wrote some notes down about several different things that I typically talk about with patients and families. She said you all had a pretty good understanding of hospice and what we do. And I know Ruby probably talked with you quite a bit last week about that. So I wanted to first see, has anyone been at the bedside of someone who's died? That's always a question I like to know. John, yeah. So quite a few of you, yeah. Can I ask what your experience was? Was it good or bad or otherwise?
I can say that I was at the bedside of my mother, and her hospice nurse happened to make a visit at that moment, and she was on her way to a baseball game. So she came in her baseball uniform. My sister was there. She was in a bed in the living room, and it was very natural and very peaceful. It was a good experience. I mean, we knew that the end was coming and she was being served by hospice. I think her hospice volunteer was there too. Everybody that needed to be was there.
That's great. Anybody else want to share anything about an experience they've had?
I shared last week that my husband was sick for a couple of years, but at the last moment when the nurse said, "This is it, say your last words," I had never thought about what to say at that last moment. And I wish I had thought about it. Somebody should have said, be thinking about those things, because I really was at a loss.
Thank you. That's a great thing to share. I think, part of, in our society, a lot of time, particularly in medicine, we feel like death is a failure. And we sometimes forget that death is the natural end to what happens to all of us at the end of our lives. And so part of our job in hospice is to help patients and families figure out how to navigate what's happening, both to them emotionally, because that's a lot of what's happening to them, but also physically. And it makes a difference. Sometimes people have had a very long chronic decline with a long chronic illness. So a lot of people, especially in our state, as they get up in age into their 70s and 80s, have a lot of chronic illness. And so they may have had multiple hospitalizations and been sick for quite a while from something. But some of our patients get sick very quickly and have a very fast decline. And so those people to have very different kinds of deaths, which I think is the first thing sometimes people don't realize is, the chronicity of an illness sometimes affects what happens at the end of life. And so when people get sick all of a sudden, whether it's a bad infection or accident or a big stroke or something like that, their decline tends to be much more rapid at the end of life, typically, not always. But when people have been sick for a long period of time, they tend to have a longer decline at times. And sometimes I talk with patients and families about thinking about how if your body is used to functioning under a lot of stress, then sometimes you get used to that and are able to function under more stress. And so that oftentimes will have a difference in how long people. So So that's something that we talk quite a bit about with patients and families about what to expect as far as a timeline. One thing I do always tell families is that in medicine, we are not very good at prognosticating. And so we're very good at telling patients, well, we think that you have lots of medical issues that are going to be limiting and going to be causing the end of your life, but we are not good at knowing when that's going to happen. And so I always tell, when I'm teaching with medical students and residents, I tell them, you need to talk about generalities. So we talk about days to weeks or weeks to months, and we don't talk about specifics, because for as much as we know about the human body, we do not know a whole lot. I always think we don't know much more than we do. And so it's always very disconcerting to patients and families, particularly when they come to our hospice house, if a doctor has told them that they're going to die in a certain amount of time. And so that is something I always discourage my students and my residents. I tell them, never tell somebody when they're going to die, because it really is going to be correct. And inevitably somebody will be told at the hospital, we're going to stop this medication, or we're going to stop dialysis, and you're going to die in 3 days. And then most of the time they're at the hospice house looking at me going, well, I was told this was going to happen in 3 days, and that has not happened. So that's always a very concerning thing for patients and families. So we really talk about generalities when we're talking about prognosis and what's happening at end of life, because I think that's a really hard thing to put a finger on. Let's think. So that is one thing I think about when I'm talking about death and end of life with patients and families. Couple things symptom-wise. And please feel free, pop in with questions anytime you have a comment or a question. I'd love to hear. So a couple things Laura had asked about symptoms and things at end of life that we see. One of the things that's a really big deal to patients and families, particularly here, is nutrition at the end of life and eating at the end of life. You know, in our society especially, one of the ways that we show love to each other is by feeding each other. I don't know if you've noticed that, especially in our churches. I bet that's a big deal. But when people get near the end of life, they don't want to eat. And I guarantee that does not matter what you are dying from. When you get close to the end of life, your body knows that we can't use food for what we normally use it for. So we can't take that food and make it into muscle and get energy and do all the things we normally would do with it. So our bodies are very good at shutting off the thing that normally makes us hungry. Really, there's a sense of comfort that comes from that. So I often tell families, you really don't need to worry if your loved one isn't wanting to eat. That's okay. Our bodies are good at saying when we want to do that. And if people aren't hungry, it's okay for them not to eat. It does not mean that they're starving. It does not mean that we are starving them. It means we're listening to what their body wants to do. And so that's a really important thing, I think, to think about and to take away when you're thinking about the end of life for someone. Sometimes people will still want a little taste of something. So they'll still want a little bite of ice cream or a sip of a certain kind of pop or something that tastes good to them, but they don't want to eat or drink very much of that. And that is very normal. And I would say universal at the end of life for people. And I do try to tell families too, it does not help people to eat and drink if they don't want to, especially as our bodies get close in the last few weeks of life, because oftentimes it actually makes them feel worse. If you think about when you don't feel good, and you're sick, sometimes eating and drinking things is one of the worst things you can do just to help yourself not feel well. So that's a really important thing. That's a hard thing in our culture to accept that that's okay, but I think that's an important thing to think about, is at the end of life, eating and drinking is not something that's uncomfortable for folks. I always tell families, the fluid intake is really the limiting factor for most people. Most of us can go a long time without eating. So that's not the biggest factor when it comes to life expectancy. It's how much fluid you're taking in and how much you're drinking. And even then, I have seen people live much longer than I thought they should have without eating and drinking. So it really is not a great indicator when someone stops eating that they're dying quickly. And so that's one thing to think about when you think about folks at the end of life.
Dr.
Bev,
May I
did you have a
ask
question?
Yeah, go ahead.
I didn't know, do they feel pain? Is that like starving to death? Do they feel the pain or hunger pangs or, they are literally, that will shut down your entire system eventually, right? And that has to be painful, I would think,
Right.
but I don't know.
That is an excellent question, Beverly. And I will tell you 100% of the time in our patients, when I ask them, particularly when we get talking about maybe weeks of life expectancy, when they are hungry, they will tell people, and otherwise they don't want to eat. And so our brain has a really good way of shutting off that mechanism that makes us hungry. So you and I, if we don't eat for 24 hours, we are uncomfortable. We are uncomfortable, we're hungry. That is not a good thing. When people are starting to shut down their bodies, whether it's because their heart isn't working as well as it should, or they have cancer all over the place, or their kidneys are failing, our bodies don't feel hunger in the same way. And so it is not uncomfortable at all. And so that's one thing I feel really comfortable. I feel very, very positive to say that is not an uncomfortable thing.
Okay, so if they're able to tell us they want a taste of something, they're obviously cognitive. They can speak, they can hear, that kind of thing. So as long as they can do that, but once they start transitioning, is that the word? I don't know, into those final few days, and they're not allowed, they can't tell you they're hurting. When does that happen? Is it those 3 days or 2 days?
I think it's much, much sooner than that. So it's probably still in the time when people are transitioning, in
Okay.
that weeks before death, that people really start to lose their appetite. So most people are still very awake and alert, and able to say that they're not hungry. So very, very rarely would someone want to eat and not be able to tell you that they could. It would have to be a very extreme circumstance, but I would say universally across the board, weeks before our bodies are actually at the end, those things start to slowly shut down, and people always stop having a great appetite weeks before their death. So I never am worried that someone is hungry or starving. And if they are hungry, we're always going to say, absolutely, have something if you want to. It's not going to be much. And so that's the other thing, is you have to remember, when people do want to eat and drink, as they get close to the end of life, they are not going to do much. So it's not time to load the plate and give. It's time to say a few bites are going to satiate them, and that is all they really want. So,
Okay. And do they have an IV in at that time, or are those taken if the will says do not resuscitate? what's the black and white on that? How to figure?
Yeah, that's a good question. So people eating and drinking by mouth is very different than artificial nutrition and hydration. So two different things that we often talk about. So eating and drinking by mouth is a very normal, natural thing that we all do. But as you know, in medicine, we have lots of ways that we can give people nutrition and hydration, sometimes through an IV, sometimes through a tube into their stomach, either through their nose or through their abdomen. And so at the end of life, there's always a question, do you continue those things or not? And what I try to help people understand, because this is a very hard thing when you think about not eating and drinking, that's a hard thing to think about. When our bodies are really shutting down, again, they can't use those things to do what we need them to do. So, our bodies are meant to take nutrition and hydration and make our bodies run and build tissue and help to make us stronger. And when our body is dying, we can't do that. That's a hard thing to think about, stopping those things when they've been going on. And that's a difficult decision to make sometimes. What I always try to tell families and patients, especially patients if they can make that decision, you are never dying of starvation. You're dying of the underlying illness that is keeping you from eating and drinking normally, or that is keeping you from being able to swallow normally. So that's something that we as a society have to learn, that nutrition and hydration are treatments or are ways that we can help people, but at the end of life, they are not going to help. And oftentimes can actually make people feel worse.
Yeah.
And so it's a hard concept, because that's how we show love, right? That's how we care for people. We feed them and we take care of them. And sometimes people worry that when we stop those things, that means that we are taking away that care. And it can be a really difficult thing for someone. Yeah.
What are some of the ways that you assess a patient's comfort level when they are not able to say, I'm about a 3 today?
Mm-hmm.
When they're no longer verbally responsive, how do you assess comfort level?
Yeah, very good question. So there are a lot of things that my nurses particularly are much better at this than I am. They do this all the time, but we look at a lot of different things. So when I'm looking at somebody, first thing I'm looking at is their vital signs. So what's their heart rate doing? What's their blood pressure doing? When you're in pain, when you're uncomfortable, your heart rate is not nice and slow and relaxed. It is up. And you are sometimes have high blood pressure because you're uncomfortable. So pain causes stress hormones and makes those things happen with our vital signs. Even if someone is completely unconscious, if they're uncomfortable, oftentimes they will have a look of discomfort on their face. So a furrowed brow or a grimace, or lots of those nonverbal things that we can see when we're seeing someone in pain, we still do, even when we're not conscious. And so those are very, very important things that we look at when we're moving them and we're touching them. And then sometimes it's just, do people get more restless, or do they stir a lot when you're touching them and moving them? Because that can be a sign of discomfort. And the other piece we think about too is, how long has someone been in the same position? Do they have any areas where they have skin breakdown, or are they losing muscle mass and so they don't have as much padding between their bones and their skin? All of those things, even with nothing else going on, can cause discomfort and pain. So we know even when we're just turning someone in a bed, or moving them, that can actually cause discomfort to them. And so oftentimes we will give people medication before we do those things. There are a lot of scales that have been studied that look at a whole bunch of those different things and help to rate someone's discomfort in nonverbal cues. So we can even use those scales in somebody who can't express pain. So say somebody with advanced Alzheimer's disease who can't tell us that they're hurting. We can use scales to kind of gauge where is their pain now versus where is their pain when we give them some medication. So there are a lot of things that we look at that can give just even subtle clues to someone being uncomfortable. And it's always interesting because I can always tell when I go into a room and see someone who's unresponsive, but I can tell when they just look completely relaxed. And it's a very different look than someone who is uncomfortable. And so, you know, that is, it's almost just such a reassuring thing when you look at someone and they just look, so their face looks relaxed and their body is just relaxed. That to me always says, okay, this person is not uncomfortable at all. Now that might change if we move them. And so we need to pay attention to those things the first time we do that. If we turn them onto the other side and they get uncomfortable, then we know, okay, we need to plan for that and we need to make sure we treat that pain before we actually do that. And so that's a good question though. It's people sometimes worry because obviously when you're not awake and you're not able to express your needs, sometimes people worry that pain won't be treated correctly. So yeah, good question.
Yeah. Well, it was just, I think about that. I had someone in my life pass away in the last year, and it's like, oh my gosh, why don't they give her something so she isn't in pain, you know, starving to death? Well, you're explaining a lot by saying there's blood pressure, there's heartbeats that increase. I mean, those are things that's very comforting. But the family, do they, and I mean, if it's not a hospice thing, I mean, I wonder how often the medical staff even think like that. So to tell the family, no worries, it's okay. You know?
Yeah.
So
I think that's a I think that's a hard concept sometimes even for doctors and nurses and people in medicine to understand is that, you know, it is okay to treat discomfort, absolutely, when someone is deciding to focus on comfort. And then there are certain things that we sometimes don't do at the end of life because they can cause more discomfort. And so it's a hard thing and it's hard to learn. And that's why sometimes we talk about, not that we like to toot our own horn in hospice, but our focus is on symptoms and how do we manage them, not necessarily figuring out what's causing it. And so sometimes in medicine, we get so caught up in figuring out, why is this person short of breath? Well, it doesn't matter. Let's just make them less short of breath and work on that. And so we work on that quite a bit and try to help families who are taking care of their loved ones at home to spot those things and help them, to give them the tools to help that before they get worse. And I think that's one of the things that's hardest when I am in the hospital and seeing someone at the end of life who hasn't had that transition to just focusing on comfort, is that sometimes those symptoms don't get controlled. And that's when I worry that people are actually uncomfortable at the end of life, because
right.
we're very afraid in medicine sometimes to do the things that will make people less comfortable because we worry about, but what if I make them worse? And so it's a different thing sometimes when people are in the hospital versus when people are at home or in hospice. So yeah.
Thank you so much for the detail.
No,
Appreciate
that's
that.
a good question. There's probably some other symptoms in the, John, did you have a question? I'm sorry.
I don't want to interrupt your flow because I want to take you somewhere else. So why don't you finish?
Oh, okay. Just a couple other symptoms I always like to talk about because these are things that are not quite, pain is, you know, everyone knows that at the end of life, sometimes people have pain, and that's a big fear for a lot of us. But there are a lot of other things that can happen to our bodies that we can manage really well, but sometimes aren't expected. And so that's something to think about. So One thing that very regularly happens is congestion. And so, you know, when sometimes people will talk about a death rattle, which I hate that term, but that's a very common term that people use. And what that means is when we get close to death, so probably within a few days, our bodies start to get weak all over and swallowing doesn't work very well. And so the things that our body always makes, saliva and sinus secretions and things that we always are producing, get stuck in the back of our throats. And just, you know, if you and I have that happen, we just our throat and get on with things. But people, when they're very weak and unconscious, can't do that. So those secretions get stuck back there and it makes a lot of noise when people breathe. And I always tell families, it bothers us way more than it bothers the patient. The person who is dying is not bothered by the noise they make when they're breathing. But to the people sitting at the bedside, that can be really, really uncomfortable and scary for them. So we do a couple things to help with that. The most important thing is we reposition people. So oftentimes we'll put them up on their side, so they're really perpendicular to the bed. And so that helps to get those secretions to fall to the side of their throat and help with that. And so we'll really often turn people regularly to help with that. The other thing we do is we can use some medications to actually dry up those secretions. And there are really lots of common medications that unfortunately have the side effect of causing a dry mouth. So we use those to our advantage sometimes and use those medicines to help dry up those secretions. And that is a very common thing that happens to people at the end of life. And so that's something that you would see us use if we had that happen. Breathing in itself can have a lot of different changes at the end of life. So some people will breathe normally and just breathe more shallow until they actually stop breathing. Most people, however, tend to have lots of different patterns. And so some people will breathe very normally and then have pauses. And we call that apnea. And those pauses can come and go. And sometimes it can be very long. And so when you're sitting next to someone's bed and they stop breathing for 10, 15 seconds, that can be really distressing to people. And so we tell families it's very normal to have those pauses. It is not uncomfortable for the person who's having those. It's uncomfortable for all the rest of us. And so it's another thing that we always have to remember, that that is something that is scary for people sitting by the bedside sometimes. And just to reassure them that that's not unusual and that can happen. Sometimes people will breathe very shallow for a while and then breathe very deeply for a while. And that's usually a sign of something affecting our brains. So that's common in people who have had strokes or who have brain metastases with cancer or something like that. And so there's lots of different patterns that breathing can have in the last few days of life. And sometimes they're a sign that things are changing and that our bodies are shutting down. And so those are things that we typically will see. Like I said, most of them not uncomfortable for the patient at all. Sometimes people wonder about, do we put oxygen on people all the time as they're dying? And that's something that's very personal, depends on the patient. So if patients are more comfortable with oxygen on, then absolutely we will put oxygen on, even if their oxygen level's normal before we put the oxygen on them. Most patients, I will tell you, do not want that stuff in their nose and will take it off and leave it off no matter what. And so it's really a matter of what's comfortable for the patient, whether they want oxygen on or not. So we don't worry about, you know, when they check that level on your finger, we don't worry about what that number is. We worry about, is this oxygen helping the patient feel better or not? And if it is, then we leave it on. So that's a very optional thing. You do not have to have oxygen on at the end of life to make death more comfortable. That doesn't make any difference for most folks. So, and then the other thing I really wanted to talk about, because this is something that we don't talk about a lot, even in the hospital, I don't think our students and our residents get educated well on this, but there's a term you might have heard called terminal restlessness or terminal delirium. And a certain amount of people, and I wish I should have looked it up what the percentage is, but I would say quite a few, at least half of people, when they get close to the end of life, and again, probably we're talking the last few days, get restless. And sometimes that is manifested in kind of just wiggling around in the bed or reaching out their arms or just, messing with the sheets and just fidgeting. But sometimes that can be manifested as someone who has been bedbound for weeks all of a sudden decides they need to get up and go someplace. And it can be very frightening when this person who's really weak and is laying in bed all of a sudden decides they need to get up and go, and you can't even keep them from getting up, even though you know it's not safe for them to do that. And it's a hard thing to understand why that happens. We don't have a great idea in medicine always why it happens. Sometimes it's because we have unmanaged symptoms. So I'm always looking for, is this person having pain? Are they having a fever? Is their bladder draining normally? All of the things that we need to make sure we're looking at. But sometimes I feel like it is their brain trying to understand what their body is doing. And sometimes our brain says, you got to go somewhere. And so we've had situations where we've had, a man who's been in bed with lung cancer for a month deciding to get up, and it's taking 3 of us to keep him from get up and out of bed because his brain says he needs to go and do something. And so that can be really scary if you're at home with your family member and all of a sudden they are agitated and won't listen to you and won't take no for an answer and just can't relax and calm down. And so that's something that happens frequently, and people don't always realize that that sometimes is a very normal part of dying. And so I think I wanted to just talk about that because I didn't know if anybody had heard anything about that before in the past. So
I always thought that was what was connecting. Oh, they're going, they want to go, they see the light, they want to go, or they see their mother who died 50 years prior or whatever. And I but
sometimes
it's just a body function that
sometimes sometimes I feel like that is the case, and not everybody has that. There are some people who very clearly will talk about seeing and hearing people who have died before. So family members, their parents or friends or some other person who they have cared about who's died in the past, and they will very clearly be talking to them or looking at them or looking through us at them. That is very common. And I think sometimes people will talk about going home. That is a very common thing we hear. And sometimes they mean to their home because they're not at their home, but more often than not, and Ruby probably told you this, it's heaven, and that's where they're going. And so they'll talk about that very frequently. And so I think that's one of those very amazing things that we get to witness at the end of life sometimes, is that connection between us and something else that is there. And I have, I've witnessed it many times, and I have no doubt in my mind that that person who is getting very close to death is having communication with people who have gone before. So it's I think a very just precious thing to be able to witness. So
I would think so.
yeah.
Sometimes people have been sick and near death, and then they seem to get better for a little bit, and then they pass.
Yep.
Do you have any thoughts on that?
That's the very commonly called rally, the rally day, oftentimes we will see. And I don't think there's any scientific explanation for that at all. But I will say it does happen frequently where someone will be very, very, sleeping all the time and just not eating and drinking much at all. And then they will have a day where they are completely lucid, talking to their family, maybe eat a whole meal, and then the next day they're unresponsive. And we do not have a good explanation for why that happens. I always feel like that is the greatest gift in the world for those family members who get to experience that. It's wonderful. But we don't know why. I think it's sometimes as our brain has this last push of energy and it's going to do last few things and then it's done. But that is a very common thing to see that happen. And sometimes it's very disconcerting for families because they think, oh my gosh, are we doing the right thing? Should this person be in hospice? Are they really dying? And I always think, we just have to wait and see what happens. But more often than not, it is a very short-lived rally. And then things continue on the process that their body's on. So,
Wow.
good question. Warren had something to say.
Last week, Beverly mentioned a phrase or a word called modeling.
Mhm.
And I think what I was looking for is this something that you could 90% of the time convince yourself that death is near if the patient is doing this, whatever this modeling is? Is that
Mhm.
one of the most reliable signals that your patient is near death?
It is. I will say, so modeling is color changes that we see in the skin, particularly in people's extremities. So we see it in their feet and their hands first, and it has to do with decreased circulation. So when your blood pressure goes down and you're not getting enough blood flow, particularly to your extremities, you see those color changes in the skin. So anything that makes our blood pressure go down can cause that. But at the end of life, particularly when your heart is working as hard as it can to try to keep your blood pressure up and it just can't work that hard any longer, we will see those changes. When we see that, I usually feel like life expectancy is hours to maybe a couple of days. That modeling occasionally will come and go. So that sometimes is depending on what's going on with the patient. Sometimes their blood pressure will go back up a little bit and then come back down. But when we see that, that is a reliable marker of things are changing significantly such that their body can't keep that blood pressure up. And that is a big change that we often see. So,
Well,
yeah.
just to further that, is there another indicator that is highly reliable that death is near besides modeling?
Yeah, I think that and the breathing changes are the two biggest things. Yeah, those are the two biggest things.
At the beginning,
Oh, go ahead.
at the beginning, you asked if Eddie had been at a bedside when someone passed. And with my parents, my in-laws, and one uncle, I was only real involved in those 5 adults approaching death. And as you indicated, my anticipation of when it would occur, I was not around when any of those 5 died. 2 died at home, 2 died in a nursing home, and 1 died in the hospital. And I didn't time it to be at the bedside for any of those 5. But one thing that really surprised me, my father-in-law had seen a lot of family at Thanksgiving in Des Moines. He was at the Jewish home. And then some more families that were around Christmas. And then he decided, I've been here 4 years, and he would not eat or take medication, just like a little kid not eating carrots. I mean, so he'd seen the family at both holidays. I was dumbfounded how long his decision to wrap this up went on. But you've already alluded to it. He would take water. They had to mix stuff. He had a tendency to choke. So they didn't give him a straw or a drinking glass, but I think it was water by sponge.
Or
And
thick
I think
water and
he went on, I think he lasted like 4 weeks from the time I'm pretty sure he made the decision that I'm going to wrap this up. But taking water, they say no food, no medication. I even was surprised that the lack of medication didn't take him. But
yeah.
he just grit his teeth. But he was thirsty and he would take water. And I think it went at least 4 weeks.
Mhm. Absolutely. Yeah, I
Or
think
shoot me.
I feel like the longer I do this job, I get a little bit better at being able to know how things are going to go. But there are always people that do nothing what I think they should do. And for everything we know in our textbooks about how the human body works and how things should happen, there are people that do not follow those rules. So we had a patient this last year at Taylor House who she had a very significant injury to her brain. And when her family brought her to Taylor House, we stopped her tube feedings. She didn't have any IV fluids. She wasn't awake. She couldn't eat and drink. She lived almost a month with absolutely no hydration, no food. But she was pretty young and her body went as long as it's supposed to go. And I think that's what I tell people. Our bodies are made amazingly to work as long as they possibly can, even in the face of a whole bunch of things not working. And so that's the hard thing, is you don't know how long that can happen. And even someone like your father-in-law, not eating and not taking medicine. So things were not going well in his body. Things were changing, but we can go for a long time, even when that's happening. And that's the amazing thing to me, is that I think sometimes it's sheer will and the power of our brain and things happening that we don't understand that keep people going longer than we think. And sometimes those things actually are a factor in when people die. And we talk sometimes about how patients often will wait until someone comes to the bedside before they pass away, or they'll wait till everybody leaves and then they'll die because they didn't want people to be around them when they died. And so I can't predict that ever. And so that sometimes are the things that even in my science part of my brain, where I know this should happen and then this should happen and this should happen, that doesn't always happen. And so that's the amazing thing about what happens to us at the end of life, is that there's so much connection between body and mind and spirit and what's happening to us, that you can't just predict what's happening based on the physical body part of it, I think. So, yeah.
So given how fearfully and wonderfully we are made, and how great our bodies are at doing whatever it is they're going to do, what does Dr. Lachenmaier wish that we would talk about with our loved ones who are going to be there helping you make the decisions about how best to walk us through this time?
Oh, it's the greatest thing ever. I think just the fact that you talk about it with your family is the most, you don't have to do anything else. The most important thing you can do is talk with your family about what is important to you at the end of life, what kinds of things you want and what you don't want. So if you're sick and you can't make your own decisions, you need to tell someone else what's important to you. Do you want to have really aggressive things, or do you just want to be comfortable, and do you want to not have certain things done? And so that's a hard thing to know when you don't know what's going to happen, but it might be really important for you to think about. So for instance, if you have really advanced dementia, we know scientifically that in folks with really advanced dementia, feeding tubes do not prolong lives and actually can cause quite a bit of complications. But oftentimes families will get asked about that when they have somebody who has a very advanced dementia and is having trouble swallowing. And so you need to think about what kinds of things are important to you. What's a good quality of life like for you? Is it okay with you if you can't necessarily read the newspaper like you normally would, or do your knitting like you normally would, or be able to go and have a great meal like you normally would? What's really important to you? And so, I even think about, after seeing lots of patients who are very advanced in their dementia and can't interact with anybody, would I even want anybody to feed me in that case? I'm not quite sure that I would. And I'm struggling and thinking about, is that something I want to talk about with my family as I get older, knowing that I have dementia in my family? You know, those are the kinds of things to think about and talk about with your family. Legally, there are a few things, I brought some visual aids that I would recommend. So I don't know, oh, you probably can't see this. Let me see if I can get it up so you can see it. This is a document. So there's two parts to this. This is Declaration of Life-Sustaining Procedures, parentheses, living will, and then a durable power of attorney for healthcare directive. So this document, this is actually from the Iowa State Bar Association, and you can get it online from them for free. So if you do anything, this is, I think, the most important document everybody needs to have. The living will can be separate from the other part, which is the durable power of attorney. So, but they often go together, and you don't have to do them both, but I think it's a good idea to do both if you do them. So I'm sorry, go ahead. Take a little bit about living will talks about, and this talks about, if I have an incurable disease or irreversible condition that will either result in death in a short period of time or a state of permanent unconsciousness from which I won't recover, I don't want my life to be prolonged with life-sustaining procedures. So that means if your doctor says you're going to die in a pretty short period of time, you would say, I don't want them to do things to keep me alive artificially. So that's kind of an important thing. It does not give your doctor free rein to make all these decisions without talking to your decision maker, but it tells people what's important to you when you're close to the end of life, or if you have an illness that's so severe that your doctors don't think you can recover. So the living will, that's the part that is separate. But the other part that's really important is the durable power of attorney for healthcare. So your power of attorney for healthcare would be the person that would speak for you if you can't speak for yourself and you need to have somebody make decisions for your healthcare. So say you have a bad pneumonia and you're unconscious and you can't, you're confused because you're sick and you can't talk, and you need somebody that you trust to make those decisions for you. So this document, you can designate one person or more than one person, or you can designate two people to be decision makers together. But it tells your doctor, your healthcare team, this is who's making my decisions if I can't tell you what I want you to do. And so it's really important you pick somebody, number one, that you trust to follow your instructions. Number two, who knows what you want. So that's why it's important to talk to those people and tell them. The state of Iowa, in our code and our law, says if you don't have this document, then your legal decision makers would first be your spouse, if you have a spouse, then your adult children, and it has to be the majority of your adult children, which is very confusing sometimes. So that's a hard one. Then it goes to your parents, then it goes to your siblings, and then we go down the line. If we start running out of family members, then we start to get nervous. But it really is a hard thing when you're trying to figure out who's that decision maker and who's going to best help the patient. It might not be the person who knows them the best or who knows what they want. And so that's why this document is a really good idea if you do that, because it just gives such clear direction as to who's helping to make those decisions. Now, I know if you name your daughter as your power of attorney for healthcare, she's probably not making those decisions in a vacuum. So I hope your family is going to all talk together and make a decision together. But I need somebody to be the spokesperson and say, this is what we're going to do. And so that's a really helpful thing when you are sick and can't tell me what you want. That's the best. It's just the greatest gift in the world for your family to have that. So they don't have to wonder who's going to be the one who steps up and helps to make those decisions. It's a really important thing. Go ahead, Beverly. Yeah.
Do you have any suggestions for people whose children may not want to hear that this is going to happen eventually?
Yeah. I think that's a hard thing.
Yeah.
As we've said, talking about people dying is a very uncomfortable thing in our society. We don't like to.
Well, for them especially, they're,
Yeah.
I think their security goes away, right?
Yep, absolutely.
I mean,
What-
we felt that ourselves with our own parents passing.
Yeah, you've gone through that. I think I would partly say, selfishly from my standpoint, I want you people to do what I want. And so that's a really important thing.
Bingo.
Yeah.
They'll understand that
So-
coming from me.
Yeah.
Okay.
I think that's really important. I think it's hard to make them understand how important it is to have those discussions before something bad happens, because the last thing you want to do if there's a crisis is try to think, oh my gosh, what would mom want us to do?
Yeah.
So, if you were in the emergency room and the doctor said to your kids, if we don't do this, your mom probably will die. That is not the time for them to be going, well, what would mom say in this situation? But they should have some direction of, well, mom would say if she's not going to be okay after this, she wouldn't want us to do this. Or if she's not going to live.
I don't want to be a vegetable and waste all your.
Right. And so that's a hard thing to think about, but boy, is it easier to think about it now than it is to think about it in the heat of the moment when something's actually happening. And that's
Great answers.
yeah,
Thank
it's a
you.
tough
That's
thing to
good.
explain. Yeah.
I
just
don't
think
know if the others have that or not. That's where I'm hoping some of you might
Yeah.
have kids that, need some help with understanding where we're at. But it's okay for us to talk about it. It happens to everybody, right?
Mhm. And I
I'd
think,
like to,
oh,
I'd like
go
to
ahead, John.
follow up a little bit on that line of questioning.
Yeah.
Everybody on the screen except you knows that I practiced law for 40 years. I had conversations with many children about their parents, parents about their children, and so forth. So I always wondered, I did the best I could to suggest people who could advise them about these things like you're talking about. But is there a resource that is available that is meant for that? Doctors aren't trained for this. Preachers aren't trained for this. I discovered apparently you
Yeah.
have to learn it over time, but I did not know until I talked to Don Ellie that preachers aren't necessarily trained for this. Is there a resource we can point people to?
Absolutely. Well, and and if Don didn't think he was trained for it, he probably would have been the best preacher that it would be. But
Well, no, Don was the one who was telling me about this, and my other question was going to be about palliative care, as long as we're on Don, but go ahead.
Yeah, so palliative care is great. And I would say, you're right, doctors don't get trained well in this. I think finally the generation of physicians that's coming up behind mine is actually learning how to talk to patients and families about death and dying and what happens and why we need to talk about those things. But my generation and the doctors before me, education about this. Pastors don't always get education. Lawyers don't always know. I spoke at the association last summer, and they don't know all necessarily what happens with the power of attorney when we use it. And so palliative care, John is going to segue us well into this. So palliative care is a specialty in medicine. And so it's a rather new specialty. It's only been around for less than 20 years, where the focus is really helping to sit down with patients and talk about what are your goals and how do we make that happen with what's going on with your health. And what I talk about with patients and families is my hope is that we can make sure what we're doing with your medical care matches what you want. And so that resource of palliative care is available in all of our hospitals here in town. Have palliative care on an inpatient side. Some places have palliative care in the outpatient setting. So I'm sorry,
This
go
is
ahead,
an
John.
important question to some people. Is there a way to get that covered by insurance?
It is absolutely covered by Medicare, just like going to any other doctor you're going to go see. So, yep.
But it
Yeah.
has to be a doctor?
No, 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 no. But just like any other visit. So we have nurse practitioners who work with us. And so just like if your primary care doc said, I'm going to send you to the cardiologist, your insurance would cover that. If your primary care doctor said, I'm going to send you to the palliative care team, your insurance would cover that same way. So,
Does
Is
it
that
have to
before
be
on our
on a,
way out?
does that have to be on a referral from a
yes,
doctor?
yes. So you'd,
All right. Now,
You
what if
c-
I had a guy who came in to see me one Saturday afternoon. He
uh-huh.
wanted a will. I thought he was homeless, to tell you the truth. It turned out I found out shortly thereafter, but he didn't die until recently. He had a lot of money. He just never married and had no kids.
Yeah.
And he was somebody I really would have liked to say, you should talk to somebody about more than just the legal aspects of this.
Yeah.
But I don't remember whether he was churched, but I've always wondered whether I could have done that better.
I think
And yeah,
you could have, right. And so you could certainly have given, and I'll forward on our information to the team so that you guys would have it. So I know if you called our palliative care team out of the blue on the outpatient side, they would figure out how to be able to talk to you.
okay, that's
That would
kind of
mean-
the answer I'm
Yeah,
looking for.
whether that would mean going to your doctor and say, hey, can we have a referral to be able to do that? And even if it meant that nobody would get paid, they would still probably do that because they really would like to do that with folks. So
And
Yeah.
you don't need to be sick and dying to request palliative care?
absolutely not. The great thing about palliative care is it's for people on a huge continuum and spectrum of where we are in life. So some people have just a little bit of illness and are doing fine. And maybe they just need to have one conversation about, okay, let's get some advanced directives and talk about what's important. And they may not need anything for a long time. Some people have been sick and in the hospital every month, and they need to have a lot of palliative care and help with talking with that. And so people might be pursuing very aggressive treatments. So you might be somebody who maybe isn't very sick and you're saying, yep, I want you to take me to the ICU and I want you to put me on a ventilator if you need to. And I want everything that medicine can do for me. Or you might be somebody who says, there are some things I don't want. So I don't want to necessarily be on a ventilator, even if it means that I might shorten my life. Those people might be pursuing less aggressive care. So anywhere on that spectrum is very appropriate for palliative care.
Well, that would.
I'm going to
find-
tag on to one thing you said from my experiences. Often it is not the best idea to say, go talk to your kids. Because they may not agree. One of them may not even like you. It does
True.
happen that people say, I wish the old lady'd get out of the way. I want the farm. It does happen. So maybe telling people to think about people other than the children, perhaps a trusted niece or nephew. Just a thought I've had.
You are
So-
absolutely correct.
So
One
when
of
you
my-
said, oh, I'm sorry, go ahead.
I was gonna say, one of my palliative care nurses used to always say, when something was fishy, we would follow the money. So that's very true. You want to pick someone you trust. It doesn't have to be anybody related to you even necessarily. So, yeah.
So
So-
you said the palliative care team will, will sort of work out a treatment plan sort of in concert with your goals. Can you tell us what you mean when you say the word goals?
Yeah. So when in medicine in particular, and hopefully none of you have ever ended up in the hospital unexpectedly, we are very good in medicine at saying, well, you have this and we can do this and this and this and this and this and this to fix it. We are not always very good at asking the patients, would you like us to do those things to you before we do them? And so we are learning, and we have learned over the last 10, 15 years that we really need to include patients in the conversation about what do they want for their medical care. Because we, in the last 50 years, have gone from not able to do a lot to able to do, amazing things. Think about even when I was a kid, if you had a heart attack, there was a very good chance you were going to die. you're either going to die or right away from the heart attack, or you're going to die from the heart failure not too long after the heart attack. Now, when you have a heart attack, you come into the emergency room and you're in the cath lab within 30 minutes and you have a new stent and you're out of the door probably the next day. I mean, literally, that is how things have changed in 40 years in medicine. And so all of these things that we've figured out how to do better sometimes are more aggressive than what people want. And so we really sometimes need to think about with patients, are the things we're doing important for what's important for you? You know, sometimes the goal is not always to live as long as possible, but the goal is to live as well as I can, even if that's for a shorter period of time. So when I talk, say I have a patient with a very advanced cancer, and they're talking with their oncologist about what their options are. The oncologist is almost always going to be able to offer another treatment and another thing that they can do, but they don't always talk with the patient about, well, I don't know if this treatment is going to offer you much benefit, or is it going to make you feel worse than the actual disease you have? And is that worth it to you to try that? And so we need to really sit down with patients and talk about, are those the things that you want to do? And make those decisions so that you're really informed in what happens, instead of us saying, well, we have all these things, so we should do them. You know, that's not always the best thing. So.
Well, and on those legal forms, you know, it's pretty vague. You know, yes, don't resuscitate me.
Yeah.
Well, how long do I linger? How long do I not? So your suggestions about asking for palliative care, I can now fine tune my will,
Right.
my Iowa forms that they have that I just took to the doctor last week. I mean, she wants it in her files, my
Sure.
doctor.
Sure.
And so she knows what to do at the end. But I love the idea of palliative care, that it's a resource for us to look at
Yeah.
and fine tune. And
And
if the kids don't want to hear it, they'll get it read to them.
There you go.
Well, actually, one of the kids has the will, copy of the will, so they would have that. You know,
There's
so they know.
there's some really good resources. If you look, there's some great things that talk about helping you kind of really document what those wishes are. There's one group in California did a thing called, it's actually called 5 Wishes. If you look that up, it's an actual booklet that talks about, these are the things I want to be, you know, to happen to me if I get in a certain situation. And this is what I want my death to look like. And it'll talk about, do I want pain medicine? Do I want music playing? Do I want, you know, things like that I always think about.
Yeah.
So
What
things
was
we
the-
use. It's
That's
called,
on the 5 wishes.
it's just called 5 Wishes.
Got it.
If you
Okay.
look that up, you'll find that that's a really common one. We use one in our hospital called Honoring Your Wishes, which is very similar. So you might see that if your doctor, you know, might have that in the office.
Okay.
Thing I wanted to bring up, since Beverly had said this a couple times, is do not resuscitate. That's a term that gets thrown around a lot, and sometimes people don't know what that means. And so when I talk about that with patients, or your doctor might ask you, what's your code status? Which is a very big term, and that's something that people don't always know what that means. So when I talk about code status with patients, I say, if your heart stopped and if you stop breathing, so if you die, do you want us to try to restart your heart and bring you back? That's what resuscitation is. We don't do resuscitation on people who are still alive. So yeah, but I think that's the thing that people
pretty
don't
common,
always
yeah.
realize. Yeah. If you die, do you want us to do things to try to bring you back, to make you be alive again? That may be a very different answer than, do you want all these things done while you're still alive? So you might say, I am a do not resuscitate, meaning if I'm dead, leave me dead. That's what I want. But you also might say at the same time, if I'm alive, I want you to take me to the ICU and put me on IV antibiotics and IV fluids and high flow oxygen and all the things you can do to help get me better if you can. Those are not contradictory things at all. You might still want to pursue really aggressive treatment if there's a chance that you might get better, but you still might say, if I die, don't try to bring me back to life. That's absolutely okay to do as well. So I always bring that back because people sometimes think do not resuscitate means don't treat me. And that's not the case. Sometimes people really want a lot of treatment, but they still don't want to be resuscitated if they die. And so that's a very common thing as people get older, especially, to talk about that. So, yeah. Does that make sense? Yep. Anne, were you saying that's you?
No, my mother was 92 and she was taken to the emergency room. She had an accident. And when she checked in, they asked her if she wanted a DNR and she said yes, she didn't want to be resuscitated. So then a little while later, the doctor came in and he said, okay, do you want the DNR? He said, do you, and he listed the things, do you want CPR? Do you want this and that? And she said, well, I don't want a feeding tube, but I think the other things are okay. And he said, it's either all or nothing. Either we resuscitate or we don't. And she said, well, I always thought I wanted to live to be 100. So they took off the DNR. But so my question is, if you don't have a DNR, then does your family make a decision step by step, or is it all or nothing?
So again, I think, yeah, that doctor did your mom a disservice. So the DNR only applies if you die. And it means if your heart stops and you stop breathing, then do you want us to do CPR and put a tube in your throat and try to get you breathing again? But that is the only thing that applies to. So whether or not your mom wanted a feeding tube has nothing to do with whether she would want to be resuscitated. So she might have said, no, I don't want a feeding tube because I want to be able to eat or not. And she still might have wanted to be resuscitated. So two different things. And I think that's why it gets confusing, because people in medicine do not explain it correctly.
So if you have a breathing tube, then are you required to leave it in? Can they ever decide
No.
to take it out?
Absolutely. So here's the great thing
A vegetable.
that power of attorney, or someone who's your decision maker. So if maybe your next of kin, say you come to the hospital and you're very sick. And so your family says, you know what, we know that Anne would want us to do everything. So put that breathing tube in and try the antibiotics and try the fluids. But maybe in a few days, the doctors are saying to your family, you know, she's really not getting better. In fact, she's getting worse despite all of the things we're doing. Your family might say, you know what, she would not want us to keep her alive with machines if she's not getting better. Absolutely, your legal decision maker has the right to say, she would not want these things. We want you to stop them. Because here's the thing, all of those things we do at the hospital, even a breathing tube, even artificial nutrition, even IV fluids, they are treatments and they can always legally and ethically be stopped by the patient if the patient can make their own decisions, or by the patient's surrogate decision maker. So either your power of attorney or your next of kin, whoever is your legal decision maker. So the great thing is, even if we do a whole bunch of things, if you don't want them anymore, we stop them. And that is absolutely okay. And it's absolutely okay to change your mind, because you make your decisions based on what's happening at that time. It doesn't mean that what you did before was wrong. It just means that maybe things have changed and what you want is going to change as well. So absolutely, that's okay. Yeah.
Thank you.
I know this is a complicated deal. I'm telling you, that's why it's so for families to think about these things. So
But you're making it so sensible.
good.
And I think that is the help.
Yeah.
And Warren, I think of you all the time, give you the meds and don't let you be in pain when we're talking about this. That was his declaration for a few weeks now.
We
Yeah.
started Warren on morphine last week, just in case.
I'd prefer some good bourbon for pain relief, if that's an option.
I
But
will tell you,
I just, whatever works.
In
Bourbon's number one,
hospice, yep.
pills are distant second.
In hospice, I always tell people they can have whatever they want as long as it's not illegal. So we regularly have the bar open when patients bring those things in. Absolutely. So, yeah.
Oh, that's cute. That's
Yeah.
cute.
Yeah. We've
I
had
want to ask a
tailgate
quick
parties.
question about the directives. How
Yeah.
practically, how do you have that document available if you suddenly need it, or you're in an accident and you're in the emergency room? How do you communicate that or get a hold of it?
Good question. Thankfully, with that document, you can decide how many copies you want out running around in the world. So the original document gets notarized or witnessed, but you can make copies of it. So when we do that with a patient, the patient gets the original. We always give a copy to every person whose name is on that document. So everybody who's a decision maker. Your doctor should get a copy. And in the day and age of electronic health records, the hospital should have a copy if you can get. So depending on whether your doctor is in with your hospital, it might already cross over. So like say, just in my system, for example, in UnityPoint, if you have a UnityPoint doctor and you give them a copy of that document, I can see that when you're in the hospital. If you have a Mercy doctor and come to a UnityPoint hospital, those things wouldn't necessarily cross over. So you might need to have one at the hospital as well. I always tell people, take a picture of it on your phone.
Okay.
Let's take a picture of it if they want to have it so that they've got it right there just in case, because it's not as great as the real thing, but it's a good place to start. And that's a really important thing. But that document, so the durable power of attorney, the living will, you can make copies of that one. What you have to make sure is if you ever change it, you don't want the old copies out there floating around. So you got to get rid of the old copies and make sure the most recent one is the one that your doctor has. That's the most important thing. So I think as long as you have one, your decision maker has one, and your doctor has one, that's the most important people to have them.
Thank you.
There's another, I don't want to confuse you, but this is another form you might see. This one's different looking. So this is orange. So this is a state of Iowa form that you might see at your doctor's office or at the hospital. This is an actual form that is an order. So it's called, typically the vernacular you'll hear is an I-post, and it's an Iowa physician order for scope of treatment. So this is actually a physician order or a nurse practitioner order that you can have on you at all times that tells somebody whether you would like to be resuscitated. And it also gives a little bit of guidance on what kind of treatments you would want. And this is a document where you would only have one copy. You wouldn't want to have lots of copies of this because this is an actual order. So we try to do these most of the time on folks who are living in long-term care or in nursing homes, who might end up in the emergency room without their family there or without their decision maker there. So this would give the emergency room doctor some directive as to what they would want. And this is an actual order from their physician. So you might see this one around as well. This is not as important if you are still able to make decisions for yourself or still speak for yourself as it is for somebody who can't do those things. And so you might see that around as well. But it's another tool that we have, and that's actually a state of Iowa form that helps people know what you want if for some reason you couldn't tell them. So you might see that one around as well. That is still not as important as the power of attorney, in my opinion. So that one's still much more important. Yeah, so lots of good questions. Oh,
You're doing great.
fabulous.
Thank you. Thank you.
I was trying to think if there's anything else I was going to tell you. Funeral plans, very important. So if you can make them, it's a great idea to do that for your family. That's a very helpful thing. One thing I wanted to mention, if you ever think about wanting to donate your body at death, so Des Moines University, University of Iowa, And most medical schools have a body donation program where you can actually donate your body, and then the students will be able to learn from that. That's something, if you're interested in, you want to pursue that long before you die, because it's not a fast process. So that's something I think that's important to know, just in case somebody ever thinks about that. So, yeah.
Would the family get the body back for cremation?
Yes. So typically what they'll do at the end of an academic year, a lot of them will do a service memorial for the people who have donated their bodies, and let those students learn. And then the families the bodies would be released then to the families for burial or for cremation, whatever they would want to do. Yep.
Oh
So,
my gracious.
yeah. And it's
What
something
about
so-
organ donation? Most of us are senior citizens on this screen. Are our organs any good at this point?
Absolutely. You know, there are a lot of people who are very old who have very good hearts and lungs and kidneys. So if that's something you are, I mean, I think that's yep, eyes. So, you know, if that's something you are interested in, that's something that I would tell your family for sure, because that's one of those things that's a specific situation where you might have a significant brain injury or something and still be able to donate organs. And that's something your family would want to know is important to you. So that's one of those things to talk about, you know, and tell your family, if that's possible, I would like you to do that. Absolutely. So, yeah, that's a good thing. Let's see. I
Why
think
are our organs still good when the rest of our body is declining?
well, when, you know, if you have a long decline from lots of chronic illness, probably not. But in the case of body donation, absolutely, that is a very worthwhile thing for those students to learn from. So if that's something you're interested in, then that's a really worthwhile thing. Yep.
Do I get a tax deduction for donating?
I do not know
It
that.
has to be worth more than $250.
There you go.
I was gonna say he's
You're
worth
priceless.
$1 million. He's
That's
worth
right.
$1 million. I wouldn't give you a plug nickel for another one, but I'll take this one.
That's right. That's right. So
Thank you, doctor. Oh my
you're
goodness.
so welcome.
This was good. I missed the first half hour. Why don't you go back and rerun that for me?
I think they're recording it, so you probably can watch it. There you
That's right. Bruce's Magic Club meets once a month. So once a month, I have to hear that joke and then remind him that we are recording this and we'll put it on YouTube tomorrow.
There you
Oh.
go.
All right.
And he's required
He's
to watch it.
liking that idea.
He's
It's
required to
smart.
watch it. Yeah.
Yep.
We don't let him come to the next class until he's passed a quiz on this one.
There you go. There you go.
You mentioned the ICU. At,
Oh, dear.
do you recall the downhill skier, Peekaboo Street?
Uh-huh.
And she became a nurse in the ICU, and she answered the phone. She'd say, "Peekaboo, I see you."
Oh, gee.
Beverly's thinking, are we sure we don't want to trade him? No.
Yeah.
You can see,
Oh,
Doctor,
goodness.
you picked the right night to be here. He was gone for 90%.
Ah,
Good timing
I
on your
was-
part.
I
There we
was
go.
just going to say, folks, it's been a wonderful time. I think I need to get off because I have to meet with somebody else at 8:30, and I could have done that just before Bruce said that.
there you
So,
go.
goodbye.
Good night,
Bye,
John.
John.
I'll send my contact information, my email and things like that, and some contact information for palliative care, and maybe the links for the durable power of attorney, things like that, so that you guys can disseminate that to your group. If you want to do that, I'll send it to you guys at the office. So
That's
Great.
marvelous. Thank you so much
Yeah.
for that.
Thank you,
Yeah.
doctor. Oh,
well,
So-
and you know, spread the word.
Zoom
Talk
applause.
to your friends. So thank you so much for inviting. I know Ruby had a great time talking with you, and we really appreciate the invitation. So thank you so much.
Thank you so much for being with us.
Thank you.
Very
You're
good.
so
Thank you.
welcome.
It was
So
very
welcome.
helpful.
So next
Good.
week, y'all, we will hear from Brad Kurtz, who is a funeral director. So we've gone chaplain, doctor, funeral. So it's all working in order here. Brad Kurtz is a funeral director. He is the director of marketing with Cedar Memorial Funeral Home in Cedar Rapids. And so he works with families on advanced planning for funeral services. So going through all of the decisions that Becky doesn't get to do, but then Brad does. So he'll be talking with us about that next Monday. And then we're gonna then look beyond your funeral. So on the subsequent weeks, we're going to talk a little bit about, okay, now that all that's done, what do I do with my stuff, and what do I want my kids to remember about me, and some of those longer term questions. So this, as we line up guest speakers, it's always a little bit of a crapshoot who's going to be available which dates, but I feel like we just got everybody on exactly the right dates in the right order.